I'm going to switch gears for a minute, and I will acknowledge it's always hard to follow Megan Ranney, but I'm going to talk a little bit about interpersonal firearm violence. So Megan correctly pointed out the stats around firearm injuries as a whole, acknowledging that about 2/3 of them are due to suicide. But among youth populations between the ages of 16 to 24, firearms are the second leading cause of death, and about 60% of those are due to interpersonal violence. So the ratio flips in our younger population, and that's where you saw that spike, especially among African American and Hispanic populations, among African American youth, firearms are actually the leading cause of death and have been for well over a decade. And the ED is really an underutilized setting for doing violence prevention work, and I'm going to talk a little bit about some of the stuff that we've been doing. And one of the questions I often get asked is why the emergency department? I mean, ED visit can serve as a teachable moment for intervening with youth. Youth who are involved and engaged in interpersonal violence may not be in school, so they may not be reached by school-based prevention programs. They may not have a primary care physician, especially as they're transitioning from a pediatric provider to an adult provider. And so we really are the place in the emergency department that sees these folks. And so we're really the place where they come into contact with the system before they end up engaged in the criminal justice system, which has its own host of associated negative outcomes with it. The other reason to do this kind of work in the emergency department as opposed to among inpatient hospital patients on inpatient units is because the majority of people that we see in the emergency department go home. So about 90% of all youth who come in the emergency department get discharged. 84% of those who are there with a violent injury go home, and about 50% of those who are there with a firearm injury go home. So we see them and we discharge them, and they go back into their communities, and we've done nothing about the fact that they're engaged in firearm violence. And if we did that for stroke or cardiovascular disease, and we didn't address their smoking or their high blood pressure or any of the other range of risk factors that we've identified for their disease, we would be negligent as physicians, and I feel the same way with regards to violence prevention. And violence really is similar to cardiovascular disease or stroke. It's a recurrent disease, interpersonal violence. So we see among the patients, we see about 20% of interpersonal violence is related to firearms and has the highest severity injury, not surprisingly. That population of folks has high rates of substance use. About 57% meet criteria for a drug use disorder by the DSM criteria, and about a quarter meet criteria for an alcohol use disorder. About a quarter of the people who are in the emergency department on that day that they're there for a violent injury report that they are going to retaliate for the incident that brought them in. So again, high risk time and an opportunity to intervene to prevent future violence. About a quarter of them tell us that they have firearms, and about 80% of them have acquired those firearms illegally. And firearm violence, we know, tends to be more of a planned event than a reactive event. So because of that, we have the opportunity to intervene and try and decrease that retaliatory violence in the emergency department. We know that they have bad outcomes. So if you're there for a violent injury, about a third come back within the next 2 years for a repeat violent injury. Within the next 2 years after a violent injury, about 60% of youth are involved in firearm violence. Either is the aggressor in the event, the victim, or somebody who ends up in the emergency department or dead because of a firearm injury. And about 50% end up in the criminal justice system. And we know that as you get engaged in the criminal justice system, it impedes those normal life milestones that we all do. So family formation, getting a job, having long-term employment, all of those issues, those developmental milestones get disrupted and portend for worse future outcomes. So, and we know the things that predict those outcomes. So higher severity drug and alcohol use, post-traumatic stress disorder, attitudes that favor retaliatory violence, and having a firearm. So we know these are things that we can intervene on when somebody's in the emergency department to prevent those future outcomes. So I'm going to talk a little bit about some of the work that we've been doing to try and think about how to intervene with these populations. One of the first things that we think about a lot of times is how do we identify somebody who's at risk for engaging in firearm violence. And we did a study where we used machine learning techniques to figure out a risk score that we could ask in the emergency department. And it's called the safety score. This work was published in the Annals of Internal Medicine. And what we tried to do was develop a scoring system where we could ask patients a series of non-threatening questions. So instead of, are you going to go out and retaliate for the episode that happened today? Or are you, have you shot somebody recently? We asked them these non-threatening questions. So we took those other questions out and we did a machine learning algorithm and determined what an ideal risk score would be that had the highest ability to predict future engagement in firearm violence. And these were the 4 questions that came out in the analysis. So, have you been engaged in a serious fight in the past 6 months? How many of your friends carry a knife or a gun? We know that peer firearm carriage is a huge risk factor for engaging in firearm violence. What's the environment you're living in look like? So in the past 6 months, how often have you heard guns shot in your neighborhood? And how often have you been threatened with a firearm? We know that a lot of violence, especially interpersonal violence, is reciprocal, meaning that people who are engaged in both getting victimized are also engaged in being the aggressors. And so asking about victimization helps to pretend their involvement in future firearm violence. And so the safety score, the higher your score, not surprisingly, the higher your risk for engaging in firearm violence over the next 2 years. And so that's a way of identifying who should we be intervening with that's science-driven and science-based. So once we've identified that population, what do we do with them? So there's a lot of different ways that we can intervene. We can intervene before somebody ends up in the trauma bay for a violent injury by identifying them early on and identifying who needs interventions and who's at the most risk for future engagement in violence, and doing interventions with those folks. That's sort of our area of primary prevention, primary injury prevention. Or we can do interventions later on in the secondary prevention realm after they're there for a violent injury, and how do we prevent them from having those repeat violent injuries and the retaliatory violence that I talked about. And so I'm going to start by talking about some of the stuff that we're doing in the primary prevention space, and then I'll talk a little bit about where we're going in the secondary prevention space. So one of the kind of early studies that showed efficacy in preventing violence outcomes was the Safer Teens study. So this was a selective brief intervention for alcohol and violence, and it was showed efficacy in a 3-arm randomized control trial. I'll talk a little bit more about the structure of the trial in a minute, but basically 14 to 18-year-olds who came into an emergency department who were seeking care for any reason, a medical reason, injury reason, whatever, who screened positive on a screening questionnaire for recent alcohol use in the past 3 months or recent fighting behaviors, either as the aggressor or the victim, got enrolled in the trial. And we did, basically they got randomized to one of 3 groups, either a therapist-delivered brief intervention, a computer-delivered brief intervention, which I'll talk a little bit more about in a minute, or into a control group where they got a resource brochure around violence. What was the intervention? So the intervention was basically a 30-minute counseling session that used a theoretical framework called motivational interviewing, which basically is a technique of doing counseling where you focus initially on identifying what the kids' goals are and kind of what their current behaviors are, and developing a discrepancy between their current behaviors and their future goals, with the idea of identifying for them that, hey, you know, they're engaged in violence and that may not be the way to achieve their goals, and they start thinking about trying to change their behavior. And that's sort of what we term sort of the why part of the intervention. So why do I need to change my behavior? And the how part of the intervention is to provide them with some skills, cognitive behavioral skills, around how to navigate situations where there may be drug and alcohol use, how to effectively communicate with people without escalating to violence, how to resolve conflict by nonviolent methods, how to not carry a firearm. And so this 2-phase sort of approach, delivered in the emergency department in parallel with their ED care via a counselor, and I'll show you in a minute the data, was shown to be effective. I said we did 2 versions. One version was the therapist actually walking through the intervention with the participant. The second version was a completely computerized version, where it was you handed the kid a tablet and they walked through screens and scenarios with a peer therapist who delivered the same components of the intervention. And the idea there was if we could hand somebody a tablet, that would be a really low-cost way of doing a violence intervention if it worked. And I'll show you in a minute that that version did not work, but the therapist version did. Well, and I think it speaks to, and we found this over and over again in the work that we've been doing, is that these kids want to tell their story to somebody, and the counselor is really a person who they can tell their story to, and the empathy that the therapist delivers can't be delivered through this computer-based version. So what did we find? So we found that out to a year, the therapist version, which is the red line, decreased severe peer aggression events. So events where somebody would go out and be the aggressor in a fight with another peer. And that was a number needed to treat of 8. So really you only need to deliver this to 8 kids to get one of these positive results. And if you think about a lot of the other interventions that we do in the emergency department, For patients who come in with an MI, the number needed to treat for aspirin is 50. So this is really a beneficial intervention. Victimization results were a little bit more mixed. We did see reductions at 3 months out, and at 12 months out. The 6 months out was a little bit mixed, and we also saw some reductions in the computer group for that portion of the intervention. We also saw reductions in alcohol consequences. So these are things like driving under the influence of alcohol, alcohol-related fights, alcohol-related suspensions from school, and we saw reductions in those in both groups. Although it was primarily a peer violence intervention, we also saw reductions in dating violence outcomes, even though it wasn't geared towards that. And we looked at a subsequent cost analysis for the Safer Teens intervention and found that if we implemented this in a single trauma center over 5 years, could prevent upwards of 4,200 violent events or consequences over that time period. And that would cost anywhere between, in a sensitivity analysis, anywhere between $4 and $55 per event or consequence averted. So if you think about even the worst case scenario of $55, you consider the average ED visit is about $1,300, and these figures are old. These are a couple of years old now. The ED visit cost rate has gone up, I'm sure. A tetanus cost is about $129, and a bag of IV and saline is $417. That balanced against that, the cost of doing this type of intervention is negligible. So where have we moved with this work? Well, we've taken this and packaged it in an online package on saferteens.org and are working on disseminating it. As Megan said, first you show efficacy and then you move towards translating it into the clinical space and the clinical environment, and we are doing that now with taking this intervention and introducing it into the standard workflow in emergency departments and looking at some of those ways of implementing it that can be successful. And I'll say we've taken that work and now morphed it into looking at how do we apply it specifically to the problem of firearm violence. Kids who are involved in firearm violence are going to be a little bit more severe than the kids that were initially in Safer Teens. And so what we've developed and are currently in the process of testing is a multi-session intervention. So we start in the emergency department with kids who screen positive for carrying a firearm, and we do a behavioral intervention with them that includes that motivational interviewing component and that cognitive behavioral skills training. And we actually added a component of care management, which is linking them to resources in the community in an active way where we help the kid link to those resources. And we know that these kids are likely going to require more in terms of intervention, both in the terms of content and in terms of the intensity of the intervention. So they're not just going to get the ED session, but they're also going to get multiple sessions after the ED that are going to be delivered by a therapist, either over the telephone or over a video chat. In addition, we have interspersed in between the sessions the delivery of electronic content via a smartphone app. So we've shown that kids will successfully do daily surveys where they answer questions about their violence and substance use and other behaviors. And we can then deliver tailored, targeted messages that are using motivational interviewing and cognitive behavioral therapy methods. And we're hoping to show that that will be successful at intervening in between these therapy sessions, that whole package of a very intensive intervention can have an effect. And so we've encased all of that in a smartphone app, and I have some screenshots of the app here. So we have some motivational memes that we've included to engage the kids. We have surveys that we ask them on a daily basis around their alcohol use, why the motivations behind carrying a gun or not carrying a gun for the day. The whole app-based intervention components are based on identifying, again, from a motivational interviewing framework, their strengths and their goals, and really trying to enhance those as part of the framework of the intervention. We deliver tailored messages on a daily basis via the app. And then we have infographics that we've created to help as a component of the cognitive behavioral training around skills. And then it's linked into the resources that are provided from a care management perspective. There's also a GPS component where we get information about where their recent fights or recent substance use has been. And then we program that into the app, and then the phone can send them automated messages when they enter into the GPS zone around those locations. And then, as I said, there are a whole host of resources that are embedded within the app with links that we can help to link folks to community services. And we're doing this work in Detroit and Flint, so we have it both programmed in for the Detroit and Flint communities. So we don't know if this works yet, but this is kind of where we're going. It builds off of the Safer Teens work that we've been doing. And this is NIH-funded work. So when people talk about whether or not you can be funded to do firearm research, you can. And this is an example of the type of work that we're doing in that space. So I'm going to talk for a second about secondary prevention. So intervening after the kid has already ended up in the emergency department for a violent injury. And a lot of this comes out of the NIH State of the Science Conference that happened in 2004 around youth violence, which said that, again, hospitals and emergency departments are key settings to do interpersonal violence prevention. And noted that the hospital programs that were out there, and there are a number of them, Youth Alive in Oakland, within our reach, and there's a whole national network of hospital-based violence interventions, were really built on a kind of care management model that was linking youth to local available services delivered by credible messengers in the immediate post-injury space. But also acknowledged that there were a number of limitations to the current programs. And there was actually a recent scoping review that looked at these programs. And one of the problems is there hasn't really been any true effective evaluation of their efficacy. So we don't know whether these work or not. And there's a number out there that are operating in this space, but there's been no real strong randomized control trials of their efficacy. Most of the ones that have been done have been low sample size, more pilot level work, or retrospective studies. They have varying degrees of outcomes. And so we really have, I think, in essence, in this emergency department space, kind of put the cart before the horse, because we've disseminated these programs. We've moved past that stage that Megan talked about where we show efficacy into the space of disseminating these programs without really knowing whether or not they work. And so I think there's a need from a research perspective to back up and do some formal testing, and I'll talk about that in a minute. But one of the things that has come out of this work, I think, is we've learned a lot of lessons about what we think probably works. So we think that with kids who are coming into the emergency department, really engaging and enhancing their protective factors, so getting them involved in positive peer groups rather than negative peer groups, and safe activities, forming mentorship relationships, enhancing their social, cognitive, and emotional skills, as I kind of talked about already, addressing their alcohol and drug use and referrals to mental health services, and really linking them with community services are probably the right types of things to be doing. We just, again, have not shown that in terms of efficacy yet. A lot of the earlier programs were really focused around kind of scare tactics, things like taking kids through a tour of the trauma bay or the morgue and trying to show them what could happen to them potentially if they got injured. And those have, by and large, been shown to be totally ineffective. And so really, so we've learned a lot of good lessons about what we think works and what we know probably doesn't work. But again, I think there's really some work to be done in this space around what does the optimal intervention look like and how do we test it in a randomized control trial way. And at Michigan, we're starting to do some work on that right now. And I'm going to talk about this trial that we're just starting up. This is a trial that looks at addressing post-assault injury intervention for kids. It's a 3-arm randomized control trial that's going to test 2 versions of an intervention. So it starts with kind of similar to the Safer Teens work, an in-ED session that it combines motivational interviewing and cognitive behavioral therapy and care management, and then delivers 8 post-emergency department sessions remotely. And again, higher intensity for what we think are probably more severe kids who need more intensive interventions to decrease their outcomes. And looking really at their rates of recidivism, their engagement in the criminal justice system, violence, substance use, mental health issues. And then the second version of the intervention that we're going to test is what's called an adaptive intervention. So I told you 1 session in the ED plus 8 after the ED. That's based on what we think probably is the right dosage, but we don't know that. And so an adaptive intervention allows us to adapt the dose and the intensity of the intervention based on how the kid is doing. And so in this arm of the study, what we're going to do is test a artificial intelligence algorithm adjusting the dose of the intervention either up or down depending on how the kid is doing week by week based on daily surveys that are done. And this uses an artificial intelligence technique called reinforcement learning. And basically what reinforcement learning is at a basic level is you take a bunch of information, data on how somebody is doing, in the context of what's called state data, or some data around what their baseline retaliatory attitudes are. I talked about how that was important earlier on. Their behavioral intention for changing behavior, how they've been doing so far in the intervention. You take that in the context of their kind of daily violence assessments, and then you can decide week by week whether or not they need a full intensive therapist-based intervention, whether they can step down to a lower intensity text messaging type intervention, or whether they can step down to nothing. So for some kids, it may just be that 3 sessions are enough, and they're on the pathway to changing their behavior. For some kids, it may be that they need the full 8 sessions of intensive therapy intervention. And so in this way, what we're trying to do is develop a method for obtaining the same types of outcomes and results at a lower cost, because we know that the tailored text messaging and obviously doing nothing is lower cost than the intensive having to have a therapist deliver an intervention. And so this trial has both a randomized control trial looking at efficacy of standard intervention, but also embedding within that a non-inferiority trial comparing the 2 interventions to see if we get similar outcomes with the artificial intelligence version, and then also looking at the cost of those 2 conditions. So that's some of the work we're doing in this post-violence intervention, secondary prevention space. And again, this study is going to oversample firearm injury patients, so we'll get a sense of how it affects firearm outcomes specifically. I'm going to shift gears for a second and talk a little bit about the FACTS Consortium, which if you go to the talk tomorrow by the plenary session, you'll hear more about. But the FACTS Consortium has been around for about a year, and it's the Firearm Safety Among Children and Teens Consortium, which is really was funded by the NIH in 2017 and was really the single biggest investment in firearm injury prevention research in over 20 years. And I think this was really a recognition both of the lack of research that had been done in this space, and also the recognition, as Megan talked about, that firearm injuries are the 2nd leading cause of death among children and teens, and that they have been increasing over time since 2010. And the FACTS Consortium was really funded to develop research capacity for the field. And so around that has 4 main aims. One is to define a pediatric-specific firearm injury research agenda. So what do we need to study in this space? Aim 2 is to conduct a series of course pilot studies to provide preliminary data to inform larger R01 and NIH and CDC scale studies. Aim 3 was really around compiling the data that's out there into a data archive, because we know that we've had limited data over the past 20 years, but what do we have and how can we combine that data in a sophisticated way in order to allow people to do and answer new research questions with the existing data that we have. And Aim 4 was really to train new scholars in this area as a pipeline for future research. And the consortium brings together 25 investigators from 14 universities around the country. And it's really a mixture of senior level investigators who've been doing this work for years and junior level investigators who are just getting started on the road to doing this kind of work. And it's led by Mark Zimmerman and Rebecca Cunningham from the University of Michigan. And Megan Ranney is a part of the FACTS Consortium, and really is focused squarely on preventing firearm injuries among children and teens. For the past year plus or so, we've been really focused around Aim 1, which is developing this research agenda, and have organized ourselves in these work groups that are focused on the surveillance and epidemiology of the problem, risk and protective factors, secondary prevention and long-term health outcomes, primary prevention, secondary prevention, policy analysis, and how do we enhance the data and methods in this field. And this sort of dovetails with all the work Megan talked about earlier around how do we organize ourselves in a public health model. And I'll mention that in the interest of collaboration that Megan talked about, we have a robust stakeholder group of people who are gun owners, people who are in the military, people who are religious leaders in their communities, people who are part of schools and the educational system, people who are part of law enforcement, medical examiners, and really focused across all intents of firearm injury. So not just the interpersonal violence I was talking about earlier, but suicide prevention, unintentional injury prevention, and mass shootings and school shootings. As I said, for the past year or so, we've gone through a pretty rigorous nominal group technique process to develop a research agenda for the field, and this has included both a review of the existing literature that's out there as well as gathering stakeholder input. And this research agenda will be coming out within the next month or so in JAMA Pediatrics. And in addition to that, we have five scoping reviews that were reviews of the existing pediatric literature on this topic that will be coming out as a package in the Journal of Behavioral Medicine in the next couple of months. The area where we're really focused on now strongly is this pilot work. And so that research agenda that we developed has led to a series of pilot studies to try and address some of the fundamental questions that we identified. So we're doing a national survey that combines parent and adolescent dyad data to answer questions around perceptions in the home around guns, gun safety, counseling by physicians, and a whole host of other questions. We're doing a study that looks at agent-based modeling simulation for interpersonal violence. So how do we adjust the levers of both policy and behavior and greening and other interventions that we can do now in communities that have high levels of violence to tweak and figure out from a simulation perspective what the optimal set of interventions are. We have one pilot study that's focused around primary prevention counseling for safe storage. So we know safe storage counseling works, but we don't know what the best methods are. And so we're looking at what are the right messages that we should deliver to folks who are gun owners. And we're doing that work with a lot of folks up in the Upper Peninsula in Michigan. We have an implementation study around how do we integrate doing firearm safety counseling in primary care. We have a study that looks at how do we improve the data that we're currently collecting through the PCARN network. We have a data that looks at looking at what happens on social media after a mass shooting that Megan's leading. We have an evaluation of extreme risk protective orders and whether or not they're effective and how they're effective and how people are utilizing them in the states where they've been implemented. And we have a study that's looking at state laws around restrictiveness and permissiveness of the law and their association with K through 12 school shootings. And we have another pilot study that's looking at dose response for firearm-specific outcomes with community-based violence interventions. If you want to learn more about the FACTS Consortium, you can go to the website. So it's www.childfirearmsafety.org. The website both houses information on the consortium at large, as well as has access to that data archive that we've been creating that has data that's been collected from people who have data sets across the United States and through other organizations, and it's an opportunity to combine some of those data sets and do some interesting new analyses. And the last couple things I'll talk about here, we also have on the website a series of videos that are around how to do firearm safe storage counseling using a motivational interviewing framework. And so you can go to the website and download and look at those videos. They're really in a pediatric context, but they could be easily applied to emergency medicine. And then we have several trainees who are currently doing their postdoctoral fellowships, as well as trainees at earlier stages through the FACTS Consortium, and they're starting to put out some work now that you can see. And so that's kind of where we are with the FACTS Consortium, and we're continuing to kind of move forward, and I know you'll hear more about this tomorrow, so I won't belabor the point, and I'm happy to talk about it more afterwards, but I think I've probably taken up more than my allotted time. So I think Emmy is next, maybe? Is that right? Okay.